It's really frustrating because we had an issue today with one of our hosting providers for Active Campaign. It's good that I was actually about to message you. It's good that you've actually got the direct link, because if I would have sent you a campaign, that campaign link wouldn't have worked, which is why we're going to have to record this, because I'm sure there's plenty of people who are probably going to be wondering why their link isn't working. So we'll definitely record this, and I've sent them a message anyway. So literally, I think we'll be starting the next 2 or 3 minutes, and we can do it as a recording, I guess, because I'm not sure if everybody will be able to attend, because that link will bounce, which is frustrating. But I've sent them a message, a technical problem, so it is what it is, which is fair enough. And what we'll do, Kieran, is give us literally, we'll start at 1:45. We have around 12 minutes to go. So please make yourself comfortable. Switch off your phones. That's one thing that I will do, is turn off my phone, which is always useful. Probably the only time that I get when I don't have to look at my phone, which is great. And we can be starting. What's the time? Brilliant. Okay, let's give it 3 minutes. So Kieran, I'll literally be back in 2 minutes time, and we'll be starting. So I'll see you there.
Fantastic. Thank you, Finn. Thank you.
Right. Good evening, everybody, and welcome to this webinar. I'm just going to inform you that this webinar is being recorded, and I'm just about to press the record button as we speak. And here we go. As you can hear, this webinar is now being recorded. So thank you very much for all of you who are here, who are listening to us on YouTube, listening to us on LinkedIn, and live sat with us here today. It's going to be an absolutely wonderful webinar. We are joined, and I'm very grateful to be here with Dr. Kieran Walsh. So it's wonderful to have Kieran here with us today, who is one of the clinical directors of the BMJ. So there's plenty that we've got to go through. And again, I just want to go through some housekeeping rules. Switch off your mobile phones. That'll be fantastic. Give yourself an opportunity to really focus on the message that we're trying to deliver today, and really make the most of this time. Any questions that you have, please write them on the YouTube channel, write them on the chat, direct message me. We'll be more than happy to answer them for you. So very much looking forward to it. So as I was saying, here we go, and welcome to this webinar itself. It's really, we're going to be focusing on this concept of improving pharmacy practice with evidence-based information. And it's a topic that I'm really, really fond of, and it's something that we're going to be spending a bit of time to making sure that you have a good understanding of this. And Kieran should be joining us any minute now. And while he's just making his way, I'm just going to go through bits and bobs with you to get you absolutely started. And Brian, it's great to have you here, and it's great to have everybody on YouTube. So we have James, we have Kenny, we have Martha. So fantastic to join us. Plenty of people joining us on YouTube Live. If you can join us directly through the link itself, that'd be fantastic. But you know, we are going to get this headed off literally in the next couple of minutes time. So, you know, thank you everyone for being here. It's going to be absolutely fantastic. And Kieran, thank you for being here, who's just joined us right now. And let's get right into this. So essentially, this is the plan today, and that is that I just want to make sure that you have a very good understanding of why, as a pharmacist, as a clinician, whether you're a doctor, dentist, a non-medical prescriber, or a non-medic, you need to continually educate yourself and continually learn. Very, very important, and we're going to be touching on that today. And I'll be demonstrating some bits and bobs to you regarding what happens when you don't continually learn, when you start to stay static. What I do want to say, folks, is for pharmacy specifically, there is a threat that if we don't continually develop ourselves, there is a threat that we could become de-skilled. And that's important for you to remember, because we know that with pharmacy by 2025, they'd like all pharmacists to become prescribers. So if you're not looking to gain your prescribing qualification at some point, then you certainly need to be asking yourself, where do you see yourself in the grand scheme of things? And I'll be briefly touching on that later on. So again, as I mentioned to you, we're going to be discussing about the importance of developing yourself. We're going to be looking at this concept of continually developing yourself clinically and gaining an understanding of what is this evidence-based practice. And I know some of you would be like, well, that's fairly straightforward. I know what evidence-based practice is. It's looking at guidelines and making sure you're following guidelines. But actually, there's more to it than just simply looking at guidelines. So we'll get into that, and I'm sure Kieran will be explaining to us exactly, what does this term mean itself, and how fortunate we are having the BMJ here with us and having Kieran representing them. So that's going to be fantastic. We've got 45 minutes. Out of that, we'll be spending about 20-30 minutes going through bits. And with my webinars, I love them to be very interactive. So you will have an opportunity to ask questions. We start exactly at 6:45, and the plan is to finish around 7:30. So that's essentially the agenda set for us. Now, moving forward, I think this is really important for you to have an understanding of what our vision at MedLearn is, because once you understand this, you'll also understand why it's so easy to partner up with people and organizations who share a common goal, a common vision. I've had a lot of messages through LinkedIn saying, oh God, you've got, Dr. Kieran Walsh with you from the BMJ. How did you manage to do that? How's he, he's with you on the webinar. That's amazing. And it's just sharing a common vision that we have. And when you have a common vision, then people who share that vision with you will naturally, you'll attract those kind of individuals and those kind of organizations. And that's our vision here, is I firmly believe that irrespective of who you are, your race, your gender, we all should have access to great healthcare, and it should be delivered by clinicians, whether you're a doctor, dentist, pharmacist, nurse, physio, osteopath, who are inspired and fulfilled by the work that they do. And you've heard me say it many times, I'm a firm believer that if you enjoy what you do and are passionate about it, you can certainly make a difference in this world, and you can build a better world. And keeping this vision in mind, and I've just, again, summarized to you what our vision is here, and it's about giving people access to, and I want you to focus on this term that I've used here, the highest standard of care that's available. And that's where neatly, Kieran will be explaining to us how evidence-based practice fits into this. So that's, keep an eye on those keywords I've used: highest standard of care delivered by people who are inspired and fulfilled by what they do. And the reason I say that is because life is way too short. If you're waking up and you're not happy with what you're doing, or you're not making a difference in your life, into the life of others, seriously, you might want to consider what you're doing. So, that's important for you to remember. And I think it's absolutely crucial. Now, there's our team here. There's myself. There's plenty of doctors, dentists, and nurses who work with us. But that's essentially the core team. And it would not be possible without everybody who's helped us at MedLearn, from Dr. Akib to Dr. Thompson, Dr. Sabah, Dr. Hafiz. We have plenty of individuals who've helped support this. And again, a warm, warm welcome to Dr. Kieran Walsh, who especially asked me to say, stop calling me Dr. Kieran Walsh, call me Kieran. So I will definitely remember to call him Kieran and not Dr. Walsh. So as of now, it will be Kieran. So again, Kieran, thank you very much for being here. And I want you to, all of you, just to have a read quick of what the vision of the British Medical Journal is itself. And you can see that they have a very similar vision to what we have. And that is improving clinical practice, research, and education, and essentially building a healthier world for all of us. So we're not talking about building a world or a city. We're not talking about a country. We're talking about building a better world. And I'd just like to give the opportunity to Kieran to just shed some light a bit about Kieran himself and what Kieran has been up to and how he started to work with the BMJ, and a bit about their vision. So Kieran, if you could kindly shed us some light, that would be absolutely fantastic.
Yeah, great. Thank you very much, Fahim, for the warm welcome and for the invite onto this webcast. So in terms of my background, I went to medical school in Galway in the west of Ireland, and I trained in Ireland and in the UK, in Southeast England and London. I trained in general internal medicine and geriatric medicine. I was always interested in medical education, and a job came up at the BMJ, and I joined 6 weeks before we launched our first e-learning website, and I ended up staying. So that's how I ended up at BMJ.
Fantastic. And if you could kindly just summarize in a couple of words, the vision of the BMJ, what is it that they're trying to achieve? Obviously, we have it written on there, but how would you summarize sort of what the vision, where the BMJ see themselves, or what they're trying to achieve?
Yeah, sure. Well, as we all know, all your audience no doubt know, BMJ stands for British Medical Journal. But we joke internally and externally that we're not British, we're international. We're not medical, we're about healthcare more broadly. And we're more than just a single journal. Of course, we've got the flagship journal, the BMJ, one of the best general medical journals in the world. But we've got a range of other journals, including over 70 specialist journals, but also a range of other increasingly digital resources. More about them in a second, which are designed to improve healthcare. And the target audience it is wide. It's nurses, physician associates, and of course pharmacists. We want to provide the same knowledge to the same standard so that they'll be able to work to the same standard.
Thank you, Kieran. I think that's absolutely important for us all to understand. And honestly, it can be a bit of a misnomer when you read BMJ and you think actually it's just medical, but that's not the case. And I think that's been wonderfully highlighted by Kieran today, that it's not about medicine. It's not just about one profession. It's as a profession as a whole. And we're going to be looking at that a bit more depth on how and where we see pharmacists, nurses in the wider healthcare setting itself. And again, welcome everyone who's here today. We have Abdul Qadir, great to hear, Aisha, Asma, Brian, Emma, Farouk, Kirit, Sultana, we have Liana, we have everyone who's also watching live on YouTube. So thank you for being here. And we've just started by summarizing kind of the vision of the BMJ, where we see Medlin fitting in with this. And just to highlight that it's, the BMJ is not just about medicine. It's not just about, as Kieran kindly said, about British. It's this concept of the wider healthcare community. And if you're a healthcare professional, ultimately, you have an opportunity to make a difference in people's lives. And we want to make sure that we are able to build a better world. And that's essentially what we're doing here. So thank you for that, Kieran. And we'll be spending more time with Kieran in a moment. And let's quickly look at where we see pharmacy at the moment. And what is quite important for you to remember is that the pharmacy world is changing. And I can't wait to get the opinion on what Kieran thinks about this. But essentially, the NHS is fairly clear where they see themselves. There's a shortage of doctors, and we all know this. There's 2.8 doctors to 1,000 people in this country. We know what the NHS waiting times are like. It's been increasingly difficult to meet the needs within 4 hours. There's a shortage of specialists. It's not just in this country, it's all over the world. And we saw it with the pandemic, and we are seeing that there are still places in this world who are not getting access to just simple healthcare. And not just simple healthcare, we're talking about evidence-based practice, and that definition we'll be looking at later on. So the NHS has made it very clear. We need support. And so what they've done is they've said, right, in order to get support, what we'll do is we will develop pharmacists, we will develop physicians associates, we will develop nursing associates, we'll upskill nurses, we'll upskill physiotherapists, we'll upskill osteopaths, we'll upskill podiatrists, and so on. So they're looking to the wider healthcare profession to help the doctors and so on. So what the NHS has made clear is we need to improve access to healthcare. It's important. And we know that one of the visions of the NHS was free healthcare available at the point of call. That's essentially what they want to do. And my thoughts on it are, and you're all welcome to your own opinion, but I feel that if we don't upskill ourselves and we don't align ourselves with this vision of the NHS, I honestly believe that there may be a point where you'll be downskilled and you'll be struggling to find work. And it's no coincidence that by 2025, the NHS said, or the pharmacy profession has changed, that all those pharmacists who will be qualified will be prescribers. It is also no coincidence that Health Education England has made it very clear that we are now going to offer pharmacists funding to become IPs. So these are two key pieces of legislation that's very important for you to go back and draw your own conclusions. Think about it. We talk about this term, thinking critically and analyzing the information, draw your own conclusions. But in my mind, it's the writings on the wall that we need to push ourselves forward and develop ourselves. So it's important that you're constantly doing this. Dispensing is no longer the key. We've been dispensing for years, and I think that process can be absolutely automated. It can be done cheaper, and it can be done more safely and more efficiently with the robots. I just recently went to Tesco's in Oxford, and they've replaced most of the people with the robots. It does everything from scanning, labeling, it's all robots now. So this is going to happen in pharmacy as well. It always happens. Those who innovate, they're going to survive. So keep that in mind. So as I mentioned to you, there's a whole pool of prescribers, not only medical prescribers like doctors and dentists, but we also have this term, and please don't get confused when we use the word non-medical. We're talking about anybody's not a medic. So pharmacists, nurses, physiotherapists, physician associates, and so on. So there's a whole pool of prescribers that are coming through. And again, more patients are also being referred to other individuals who can treat. There's recently a list of conditions that no longer the GP will be asked to treat. And I mentioned to you that there's a shortage of 3,000 GPs every year. So even if we said the solution is fairly straightforward, train more doctors, the issue is that even if you train more doctors to become a GP, Kieran, how long does it roughly take to become a GP after med school? 4 years med school, and then what do we have?
So if you enter as an undergraduate, then it'll be 5 years of medical school. If it's graduate entry, it'll probably be 4 years of medical school. But then 2 years of the foundation program once you qualify, once you leave medical school. And then if you want to become a GP, you're probably talking about 4 years on top of that, doing different specialty posts and also working in general practice by the time you become a GP. So you're right, it's quite a long period of time. And to become a specialist, hospital consultant, it can be even longer.
So yeah, so if you have a shortage of 3,000 GPs every year, and it takes 10 years to become a GP, you can see that that's not a solution. So it's not a short-term fix. It's difficult, and not everybody wants to be a doctor. It's just the way it is, and it's not for everyone. And we can talk about that all day. But the point is that every country in the world is looking for a solution to this. Unfortunately, I don't like to bring this up, and one of the reasons I would have, again, I really appreciate Kieran for being here, because it is a bit concerning, some of the things that are coming out through general practice with pharmacists working and sort of the mistakes that are going on. So it'd be interesting to see Kieran's point of view and how we can make sure that we are, again, treating and absolutely learning. I'm sure, we can't trust, or we can't draw our conclusion just by headlines, but it's important for us to have a look at our practice and ask yourself, are we constantly learning? Are we reflecting on things that we're doing? Are we constantly pushing our boundaries and working within our scope? But, this was quite recent. This wasn't too long ago, where we had this was what was this, 2021, 3rd of November. So it wasn't too long ago, but we had, unfortunately, sepsis being missed, and you can certainly have a look at this. This was in 2019. This was in 2020, and these are just a handful of things that I've just picked out. I mean, there's more. I do not want to make this into a negative webinar, but just to highlight that, when it's the nature of the beast. If you are going to start treating patients, then you are taking an element of risk, and it's very important for us to work to make sure that we are safe when we're treating. And that is where it's going to be great to have Kieran's input in terms of how the BMJ and how their tool can be very supportive, and also his thoughts on how we can practice more safely. And so this is what I'm finding, is a lot of pharmacists are struggling with where they see themselves in the future. And it seems to be coming up again and again that they're worried about litigation. Some pharmacists are feeling discouraged by their peers, by their colleagues. Things I've heard, I've heard things like, I don't think I'm capable, you're trying to be more than what you should do. So we don't want to waste our time with all that negative stuff. There seems to be issues with lack of structure. And I know all the complications that go around becoming an IP. And I've had a conversation with Kieran as well about this concept of just training for 6 months. And then you can walk out with a qualification that you can prescribe in pretty much anything that you felt you were competent in. And, that's essentially what we're working towards, to make that whole pathway easier. Health Education England is working towards that. The NHS is also working towards that. The universities are working towards that. So things will get a bit more better. Again, benefit to patients, plenty of benefits to patients in terms of upskilling yourself. And I've mentioned this time and time again. Okay, now what I'd like to do is again, Hibaz mentioned about time constraint, workload, and so on, is I'd like to give the floor to Kieran, and I'd like to ask some questions that you have posted in. And the first is, Kieran, it's going to be, it's to get your thoughts on, if you're a non-medical prescriber, you've qualified as a pharmacist for 2 years. So you qualified for 2 years. You're now eligible to prescribe or this 6 months course. You do this 6 months course and you essentially specialize in an area, let's say UTIs. How do you as a pharmacist or a non-medical prescriber grow your scope of practice? What do we do to become safe if we wanted to, say, develop our skills in hypertension? What would you advise as a clinician to constantly keep developing your scope?
Thanks, Fahim. So there's quite a bit to answering that question. And I think that to develop those skills, you need to think about a wide range of different things and not just prescribing. First about diagnosis, then management, then follow-up, and then other skills. So to be able to prescribe, first of all, you need to be able to diagnose, and therefore you need to be able to take a history and do a physical examination, request investigations, think through differential diagnosis. In terms of management, you need to think about non-drug management and drug management, and sometimes when to refer to a specialist. And then in terms of follow-up, it's thinking about monitoring and complications and all the other skills that are required as well, such as communication skills, team working skills, patient-centeredness. And so you need a lot of support. And you mentioned tools that BMJ provides. And one of the main one we're providing at the moment is Bmj Best Practice, which is clinical decision support, which takes you through all these different things in over 1,000 different conditions, from diagnosis and management to follow-up. It offers evidence-based, continually updated content that will work at the point of care, and it's a resource that is digital. And very importantly, I should say that it's free if you work for the NHS in England or in Scotland or in Wales. If in England, you can get on through bmj.com/HEE. If you're not in the UK, get in touch, and we'd be delighted to discuss how it could be made available. So it's a slightly long answer, Fahim, but I think there's quite a bit to it.
Thank you, Kieran. And yeah, absolutely. I think it's great to hear this because, I've said it many times, this concept of, prescribing is kind of like the end result, and not to prescribe is also a clinical decision. But before you can even prescribe, you have to know what the problem is. And I've mentioned to you that you're literally, think of yourself as you're a detective. You have a patient or an individual who presents you with a complaint, and you are trying to find out what that complaint could be caused by. To do that, like an inspector, you gather the information. You'll sit there, you'll say, okay, tell us what happened, how it happened, why it happened, what the symptoms are, and X, Y, Z. Then you may need to examine the patient. And then if you may need to do further tests like X-rays and bloods and so on. So the diagnosis is key. If you can nail your diagnosis, then absolutely that can help you with the management. And that's the next step when you go on to management. And then Kieran kindly mentioned about this concept of knowing when to refer, which is also important. And that is very important about knowing when to refer as well. And I just want to just paste this question that you've put on here, and I'll write it to everyone. Kieran has put this question on, and let's put it on all attendees as well. There you go, for everyone who is joining us today about how to get in touch with Kieran and so on. But essentially, this is the kind of the three-pronged attack you want to focus on. And I just love the way it's really been put forward to us that this tool, this BMJ Best Practice, can really put everything in a nice area for you to give you the everything summarized. And just correct me if I'm wrong, Kieran, but this is not a substitute for obviously educating yourself and keep learning, but it's going to be something that's going to augment your practice. Is that how you would view this, as opposed to a substitution?
Oh, absolutely. Yeah. Regardless of whether you're a doctor or pharmacist or any other healthcare professional, we offer support and guidance. Ultimately, you do need to develop and learn under supervision before you're even really able to use the tool and get most use of the tool. And to do that requires curriculum, requires learning, an assessment, and then putting learning into practice, and then continuous improvement and evaluation, and hopefully improving the curriculum over time. So we're not seeking to replace those things, but to support those things as you learn and as you practice. And I think that's partly about the future of clinical decision support, because it's about learning as you practice. And you said at the start that we should continually be learning, and you're absolutely right. And that means every day. And sometimes you might have an unanswered clinical question, and you might look it up on Bmj Best Practice or another decision support tool, and you find an answer and you put it into practice. The whole thing might take 30 seconds, 40 seconds. It could be the most important 30 seconds in your day, something you'll remember, something you'll learn and remember, and quite possibly, because it's in the context of clinical care and you put it into practice, something you'll ever forget.
I love that. If when you learn something and you put it into practice, you never forget. And again, as just been mentioned there, that you still need to have your baseline knowledge and you can build on that. And this nicely moves us on to the next question. And it's an interesting one. Where do you see the role of the future doctor and all these professions that are now starting to make their way through? Where do we see this? Are we looking, is this non-medical prescribing a cheap form of healthcare? I've heard this word being thrown around that it's just a cheap form of being a doctor. It's cheap, it's not the solution. Where do you see this fit? A non-medical prescriber and a medic, where do you see this fit?
So I think into thinking about the future of prescribing by pharmacists or by doctors or by any other groups, I think one thing that will become increasingly important in the future is safety, to absolutely ensure that prescribing is safe and also of the highest possible quality. And that's partly what we're trying to do by providing decision support, but there's a range of other resources that can help as well. And I think one thing that will be important in the future is integrating all these resources together. So, for example, if you're on Bmj Best Practice, you're able to link directly to the BNF, the British National Formulary, granular links to get exactly to the bit that you want to get to. I think the future will also be about integrating with other resources such as calculators. Once again, without having to log into another system, everything there in the same place, so you can work out the dose of gentamicin maybe in somebody with renal failure. And why integrate? Well, because it's a better user experience, which is always going to be the future, and also speed and access, because people want things quickly. I remember years ago when we launched our first our first podcasts, sorry, webcasts, they were about, we thought they were short, and they were about 20 minutes long. Nowadays, people tell me they want to watch videos on YouTube that are 30 seconds long or 40 seconds long. So speed and access online, offline, via an app will be part of the future. And I think also, and this comes down to safety as well, that safety of diagnosis and management more broadly, is that evidence-based medicine needs to evolve, and it needs to evolve so that it can enable the better management of real-world patients who often have multiple illnesses, i.e. comorbidities. 1 in 3 adults in the UK now have 2 or more conditions. So that presents a big challenge for management and for prescribing as well. We've launched a new tool in the past year, the Bmj Best Practice Comorbidities Manager, to help with that. But I think the future of healthcare is in some ways the future of healthcare professional education. I.e., one drives the other, and they both drive technologies, including digital technologies, to enable those things. So I think those are things that we should look at over the next 5 or 10 years. I think they're going to be important trends.
Thank you, Kieran. I like this concept of seamless integration. I was actually watching a video by Steve Jobs, and he mentioned why the Apple is different is because everything is seamless. It connects with your iPhone, it connects with your Mac, and this concept of having the user experience. And I think it's true. I think what the BMJ are doing is fantastic, and by having everything seamless works, because if you've got a calculator dose, you now have to go on Google, open up a calculator, or you've got to get your phone. But if it's all there, everything can become easier. Also, sometimes we see these tools have references, but they give you a standard reference. You want to go exactly to the point where in the BNF this is, and if it takes you there, that's absolutely amazing, which is fantastic. Now, moving on to this evidence-based practice, and honestly, before this webinar, I'll be very frank with you. I did some research on evidence-based practice. I read some articles, some journals about what is this, because my understanding of it was evidence-based practice, just guidelines, but I didn't really have a full understanding that it actually encompasses more than just guidelines. And we're looking at a bit of bigger picture. So Kieran, if you can shed some light for us here today, how do you define evidence practice? Is it just about guidelines? Is there a bit more than that?
Yeah, so when I think about evidence-based practice and evidence-based medicine, I think about the research base, which can be original research, meta-analysis, systematic reviews, guidelines, sometimes the content on one side. That's one thing. But it's got to be used in combination with professional knowledge and expertise. And it's got to be used in combination with the third thing, which is patients' values and needs and desires. And when you put all those 3 things together, the research-based, professional expertise, and the patient, there at the center of all those things, that is evidence-based medicine. One of the challenges is that when you ask people what evidence-based medicine is, they say, oh, it's all about the research, or it's about the guidelines. And it is about that, but it's not just about that. And we need to rebalance things to take in the patient's perspective and values and needs, but also the professional expertise.
Absolutely. And I think if I remember correctly, the text actually mentioned those 3 points. It said research, it says your professional judgment, your experience, and patient values. So the other 3 things that we're looking at, folks, when we're talking about evidence-based practice. Guidelines, and I've mentioned it many times, guidelines are there to support you and offer you a roadmap. They're not there to make your clinical decision for you. Guidelines are there to support you. They're there to give you a roadmap. They're there with evidence, but your professional knowledge, your professional experience, the patient's values, when you encompass all of this, coupled with research, data, that's what we're talking about evidence medicine. So I think sometimes what can happen is when we qualify as non-medical prescribers is we look at the guidelines and we see that's just the gospel and that's it. It is what it is. Remember that your own practice and the human body is a lot more complicated than just what we see. It's very important. So keep that in mind, that your own practice, your experience and patient values are very, very, very key. So that's there. And I guess we can just briefly touch on then how do you practice evidence-based medicine? Do we have a particular scenario where you can say this is evidence-based medicine versus not evidence-based medicine? How would you sort of summarize this for everybody listening today? Okay, we understand the three things: research, my own judgment, and patient values. Could you provide us with an example maybe of this is an example of evidence-based medicine, this is not, if possible? I might have just thrown a curveball at you there.
Yeah, no, that's fine. I guess, say if you have a patient with maybe heart failure, and and you're deciding what treatment you might want to give, and you might think, okay, we're going to give standard treatment with ACE inhibitors and beta blockers, and maybe a referral on to tertiary care, and that might be what the evidence base says, and that's good, and that's a solid foundation. But you also you've got to use your own professional expertise, if nothing else, to make sure that you got the diagnosis of heart failure correct in the first place, and you've done all the necessary investigations, the baseline investigations that you need to do before you start any of those treatments. So you got to use your own professional expertise. And then lastly, you got to talk to the patient, explain what the treatments are, and explain what the benefits of treatments are, and any potential side effects as well. And if you're thinking about a referral, you got to discuss that as well and ask the patient what they value, what's important to them. Do they want to go to the hospital? Maybe they do, maybe they don't. But you got to find out what's of value for them. Is it that they're completely symptom-free? Is it that they're at home and functioning and able to do small things for themselves? And then you got to put all those things together and come up with a plan. That's evidence-based medicine.
Thank you. And again, a brilliant example and key things for you to remember, that this concept of patient autonomy, patients have the right to make the wrong decision. You know, as much as we say do no harm, but essentially the patients have that autonomy. They have the right to make the wrong decision as well as the right decision, which is where, as clinicians, we must make sure that we explain to them the benefits and the risks. Absolutely, you can encourage them, you can try to persuade them within a limit. And I think that's where, when we're talking about evidence-based medicine, sometimes we miss this concept. And I'll be very honest with you, as of today, I don't think I'll forget this concept of patient values, because even as a clinician, sometimes you don't ask, you think, well, if you've got this condition, here's the treatment and that's it. But actually, what does the patient want? And tiny things, it could just be, it might be somebody who presents with some sort of sore throat, and maybe they don't want antibiotics, and it's not what I'm looking for. What I want is just a bit of painkillers to stop the infection from spreading, to stop the pain. If it's self-limiting, can I do without antibiotics? But sometimes we can rush to the gun. There's your antibiotic, there you go, on your bike, next patient. So, it's important to keep that in mind, but also your professional judgment. There might be a particular condition where it is necessary. If I don't treat you today, there's a risk this will happen. And again, I can't stress the importance of documenting your findings and also documenting your negative findings. So keep that in mind. Documentation is very, very important. So that leads us to the next question, and that is the tools and resources that are provided by the BMJ. You've already nicely focused on this BMJ tool itself. So we have a journal, we have this evidence-based practice tool. What else is available? What else is in the pipeline? What should we be considering as clinicians when we do go on, leave this webinar, to help us in our practice?
So Bmj Best Practice itself, the evidence-based clinical decision support tool, is really important. It's comprehensive, covers 1,000 conditions, and also it's seamless is a good word to describe it. The idea is that it fits with the clinical workflow, and as you use it, your workflow isn't interrupted. So I think that's number one. We also have Bmj Learning, which is our digital learning resource, which covers a range of clinical and non-clinical tools from communication skills to management of diabetes, in an interactive and multimedia format. But also, one last thing I should point out, within Bmj Best Practice, we've got an evidence-based medicine toolkit, which describes how you can learn about evidence-based medicine and practice evidence-based medicine. And also, we work hard at Bmj on how we portray the evidence. And so we've got tables that can help you make decisions, make better shared decisions with your patients. So one example is that the tables often use the PICO format, patient intervention comparison outcomes. And I think that will become increasingly important in the future. So it'll no longer be enough to say, oh, drug X works, or drug X is useful or good. Rather, you should say, in patients with disease A, intervention with drug X as compared to no treatment, or drug Y or standard treatment, achieves the following outcomes, or doesn't achieve the following outcomes, and what's the evidence that it achieves the following outcomes. So I think those are helpful resources, Bmj Best Practice itself, as well as the journals, and as well as the evidence-based medicine toolkit within Bmj Best Practice. It's all part of the package. It's all freely available.
Thank you, Kieran. So we've got plenty there, and we have one of our colleagues here today is asking, if you are not in the UK, would it be simply a case of getting in touch with the BMJ? What's the sort of process in terms of getting in touch and using this toolkit itself? Is it simply just send them an email? How can
yeah, please just send me an email. My email address is up there in chat, so send me an email in the next couple of days, and I can sort you out myself sometimes, or also talk to a member of the team at BMJ. But if one of you wants to email me, please do. Be delighted to hear from you.
Perfect, Kieran. Thank you very much for that. So again, with the tool itself, there's plenty out there. I have a question for you, Kieran, and that is, how does the BMJ tool compare with UpToDate? Now, there's obviously, you're aware of UpToDate. That's another kind of wholesale leader. Are there any similarities, differences? How does that work with UpToDate? Very similar. What are your thoughts?
So Bmj Best Practice is a clinical decision support tool that works more at the point of care. So the content is chunked up and is shorter. Our opinion is that the mobile version and the offline app version is highly rated on the App Store and on Google Play, and we get a massive amount of positive feedback to it. Increasingly, because the content is chunked up, it can be quicker to get to the answer that you want to without having to read lots and lots of text. So you can get the answer that you want within seconds. I would say that those are some of the differences between Bmj Best Practice and other resources that are out there. So we don't kind of look at it in terms of direct comparisons, but rather think about what is the exact role that Bmj Best Practice has and how it's different to the others. And lastly, I should mention once again the Comorbidities Manager, which enables the better management of patients with multiple conditions, which has been a real gap in the provision of guidance and the provision of evidence-based care until we launched the tool about a year ago. So if you look at guidelines or systematic reviews or meta-analysis, nearly all of them are about single conditions, despite the fact 1 in 3 adults in the UK has 2 or more conditions. If you go into hospital, go into the emergency department, 1 in 3 adults admitted as an emergency has 5 or more conditions. It's remarkable, the growing prevalence of comorbidities, particularly amongst older people, but not just amongst older people, increasingly amongst middle-aged people as well. So we've got to provide support for healthcare professionals who are trying to support those patients, and that's what we're trying to do at Bmj.
And I think Kieran's actually hit the nail on the head. Having used both tools itself and many other resources, I will say with the Bmj that it is seamless, easier to use, and in chunks, because the same information you could get through reading tons of textbooks and references and papers. But what I found with the Bmj is that I did find it to be easier to find the information that you're looking for, because you're not looking to write an essay from this content, but it's to the point what you need and to make the clinical decision. So I think, thank you for that, Kieran. That also answers our questions about the benefits of the tool and in terms of gaining access. And again, if you are a pharmacist in the UK, then it should be fairly straightforward because you all have NHS logins. So you should be able to nicely, will that be the same for a community pharmacist, Kieran? If we are community pharmacists, we do have an NHS contract. I mean,
if you work for the NHS, yeah, you'll be able to access the tool. If you have any problems getting in, once again, you have my email address, and I'll be able to hopefully advise myself or talk to a member of the team who'll be able to get you in as well. One last thing I should say, Fahim, if that's all right,
yep.
Is that Bmj Best Practice is a digital resource, but we've started to recruit volunteer local clinical champions who are often healthcare professionals who are qualified but still learning in postgraduate training often, who act as advocates for the resource locally, who tell other people about the resource. And we put on a program of learning for them on everything from how to evidence-based medicine, shared decision making and patient information, how to get published, how to do quality improvement, a wide variety of things. We've got lots of clinical champions. They're mainly junior doctors, which is great, but we want more interprofessional team members, and we want more pharmacists as well, to be completely frank. So if people who are on this webinar, who watch the recording, are interested in finding out more, send me an email and I'll introduce you to the person who runs the Bmj Clinical Champion Scheme, and we'll send you some information about it. We can have a chat, and no obligation, but we're delighted to have more pharmacists.
Absolutely. Thank you for reminding me, actually, because again, this concept of interprofessional learning and working with other professionals is going to be crucial to your development and also bettering patients' lives. So Hiba, you've mentioned you're interested. There is the email. You can copy that. You can get in touch with Kieran directly, send him an email that you're interested in being an advocate. And I can't encourage you all to do this, because it can certainly help you with your practice, and it can also, it's how you also network. So don't forget the value of networking, the value of building links. It's not just about being an advocate, but also a way that you can build links and relationships. So certainly if it's something that you have time, do get in touch. And as Kieran mentioned, that there's no obligation. You have a look at the package if you're interested, definitely, and uplift your profession. And we want more pharmacists there. We want more nurses on there. We want more physicians associates on there. That'll be great. One of my colleagues has asked, if you don't work for the NHS, is there a cost to this, and how much does it cost?
So if you don't work for the NHS, there is a cost to Bmj Best Practice. Don't ask me what it is, because I just can't remember from the top of my head. But send me an email, and individuals can get access as well. But in terms of kind of being economical, sometimes it can pay to get group access, if you like, rather than paying for it yourself as an individual. Fahim, you're absolutely right about networking, and Bmj Best Practice is a digital tool, absolutely, but it's a tool that's used by people, and we gain an awful lot by talking to the people who are using it, by listening to what they tell us, and they gain a lot from talking to each other. It doesn't really take much time or much effort, but we're building a small community of practice, really, and we want to widen it out.
Yeah, and I think that's a lot of you might wonder, why I do these webinars. This is the reason why. If Kieran is here, you can do exactly the same. Get in touch, introduce yourself, become part of the BMJ. That's how you build networks. So, and I keep on mentioning to everyone here on every webinar, please interact with each other, get to know, it's just a conversation. And networking is so important. If we have this dream of building a better world, this is how it has to be. So that's why with the BMJ, when you're getting in touch, not only are you getting this decision-making tool, but if you're really being active, you can build relationships, and those relationships can last and change everything. So that's important for you to remember. It's not just about being here, but it's about networking, building relationships. Everyone that's here today, do get in touch. It'd be fantastic. So Kieran, thank you for that. Now, we have around 15 minutes or so to go. And at this point, I'd like us to have an open discussion. If there's anybody who'd like to ask any questions from Kieran directly, if you'd like to ask me questions, please do go ahead. We're happy to stay. We've got about 15 minutes. If you've got questions, all well and good, fantastic. If you don't have questions, then we will leave it at that. So please, anybody here today, we have plenty of you folks here. Does anybody have any questions? Put your hand up. And if you're shy and you don't want to share your knowledge, you can put it on the chat and we can answer it for you. But if Abdul Qadir, Aisha, Asma, Brian, Emmanuel, Azim, Farouk, Hiba, Jennifer, Kemi, there's plenty of you folks here. Does anybody have any questions that you'd like to ask Kieran directly, or you'd like to ask me? Anybody here have any questions? Ruth or Salim or Sarah, anybody have any questions? And if you're shy, then please write it on the chat. It can be a bit, it's not always easy to write, to speak live, which is fair enough. But, the more you interact, the more questions you ask. It's even for those who'll be listening to this, but, we have around a couple of minutes left. So anybody have any questions? While they're thinking of questions, Kieran, I certainly have a question for you. And that is, if I, with the BMJ at the moment, what's your kind of split between medics and non-medics? Are you starting to see a growth? Is it still very much heavily medicalized, or are we getting more, have you got more nurses, more pharmacists? Who's the other group that you have besides medics on there at the moment?
Yeah, thanks, Fahim. Excellent question. So the majority of our users are doctors, and when I started at BMJ, which is a good few years ago, doctors were in the overwhelming majority. But now we've got a growing number of nurses, particularly nurse practitioners, sometimes nurse prescribers, sometimes advanced nurse practitioners, which we're delighted about. We've a growing number of pharmacists as well, and sometimes advanced pharmacist practitioners or pharmacist prescribers. The third or fourth and final group is perhaps the newest group of all, which is physician associates, which is a rapidly growing group as well. Of course, they've got their own needs, but ultimately, they're trying to do similar things, which is deliver high quality care that is safe to their patients. And so I think that they all need access to the same high quality tools to enable them to do that as well. And that's what we're trying to do.
Thank you, Kieran. So Asma, we have a question, and we'll take one more question from the floor. It's exactly 7:30. And first of all, I'll answer this one quite easily. You missed the webinar. Will it be recorded? Yes, it will be recorded. So that's easy. I can send that to you. That's there. The next question is from Asma, who goes, I'm a pharmacist working in Nigerian Armed Forces Hospital as a pharmacist. I'm looking forward for any higher education. as I'm a bachelor's, but have good experience as a hospital pharmacist. Kindly guide. So Kieran, you mentioned that there is an e-learning side to the BMJ. And does it cover a whole host of medical conditions or very specific to chronic illnesses? Can you just shed some light on the e-learning that's available?
Yes, yeah, the e-learning is Bmj Learning, which provides interactive multimedia resources on clinical and non-clinical topics, and can be used alongside Bmj Best Practice. So Bmj Best Practice, maybe when you have a really quick, immediate need that you need an answer within seconds or minutes. Bmj Learning when you've got more time and want to spend more time reading around a subject, and they both can be made available on an institutional basis. So regardless of where your institution is anywhere in the world, send me an email, and I can put you in touch with a relevant team member at Bmj who can hopefully then sort out institutional access.
Thank you for that. So I had a feeling now that everyone's starting to get a bit more relaxed. You're going to ask more questions. I'll answer this one. It says, hi Fahim, as you mentioned about networking, this is one area that I'm struggling with. I have been trying to transition from community to GP, but I don't have the IP qualification. What would be best way to start? I did a recent webinar with Dr. Hassan on working in general practice. So Aisha said Medlearn. Yes, Medlearn is a way that you could start. That's true. You could do it that way. Thank you, Aisha. The reality is that when you're trying to building relationships is more than just sending an email. So it's not just a case of that I'll just send an email to general practice and all of a sudden we will network. You've got to be proactive. I mean, how active are you on LinkedIn? How active are you in social media? I'd like to say, how unselfish are you, and are you giving something back to the community? And this might sound a bit harsh, my words, but the reality is that you need to give something back. So, I do these webinars. I'll spend as much as I can, as much as, God's given a lot, but I always like to give back as much as I can. And if you want to network, then be prepared to give something back. And honestly, it will happen. Just like I had a conversation with Kieran, I sent him an email. I said, look, this is what I'd like to do. This is my vision. What are your thoughts? Is it something that you're interested in? And it was just a case of either he would say yes or he would say no. It is what it is. Fair enough. He's busy and so on. So you've got to be proactive. You've got to be willing to get out there. And if you're struggling to become a prescriber, then certainly get in touch and I can organize that for you. So if you're saying for him, look, I can't become a prescriber, I can't find someone to supervise, we can organize that for you. But in terms of starting from, Kieran, do you have anything to say on this? How do you network? I don't know. It's something that comes naturally to me. How would you, there's this question that he's struggling. What does he do? Does he just keep knocking on the door?
Yeah, I think you're right. People should network, but and should be networking for a purpose. And you're right. Things often start off with the first post on LinkedIn or other social media site, or you reach out to somebody on one of those sites, or maybe you send them an email, and it starts with those things, and then you wait and see if you get a reply. But I encourage then as quickly as possible to kind of start having a conversation with people, because you learn so much more when you have brief chat over the phone or any of the wealth of video conferencing resources that are out now, and then you can have a quick interchange of views, and you'll find out exactly how that individual might be able to help you, how you might be able to contribute to what they're trying to achieve, etc. And it should go on from there. Sometimes you need to be a little bit resilient, and the first conversation you might have, or the first email you might send out or post on social media, you might not get a whole load of responses, but keep with it, stick with it, and you will eventually.
And I probably end on this note, that this relationship that I've developed with Kieran hasn't happened overnight. It wasn't just a random email or random LinkedIn message. You know, I've been watching and following a lot of the work that Kieran does, and some fantastic posts. And likewise, there's that reciprocal. There's some good work happening here. You're getting out there. You're pushing yourself, and then people acknowledge that, and that's just the way it is. It's not, you know, I've been on LinkedIn for years now, and after I think maybe 4 or 5 years now, the opportunity has come where I've been blessed with the chance to be, you know, in the presence of Kieran and with the BMJ. But you be consistent. Keep knocking on the door slowly but surely, and remember this word I mentioned, and I'll leave it at that, and that is about not being, it's not always about you. Be a bit unselfish, give something back, and all of a sudden things will come their way. So again, I just want to thank Kieran for this wonderful opportunity. I would like to summarize what we've discussed today. So continually educate yourself. The BMJ is a wonderful support tool that, as pharmacists, there's no reason why you shouldn't have access to this, because you do work in a community pharmacy. I've got access to it, so there's no reason why you can't get access to it. But if you can't, I've left the link here as well, and Kieran has kindly shared his email there as well. So I've highlighted it there. So if you're not sure, send an email here, or even send an email to me. I'm more than happy to answer and tell you what needs to be done. But that's what needs to be there. Use all the resources that you have to better yourself. Kieran, if you want to say a couple of words and we can end this session, by all means, you know, just a couple of words to the students, and we can, you know, have a wonderful evening, all of us.
Yeah, thank you very much, Fahim. No, nothing to add really, other than thanking everybody for attending, and indeed for taking part, and not just sitting there passively, but for sending in questions, comments, sharing resources. It makes it's such a much better experience. If you're interested in accessing Bmj Best Practice, any problems, let me know. If you're interested in the clinical champion role, we'd be delighted as well. We'd very much welcome that. Thank you.
Thank you, Kieran. Thank you, everyone. So clinical champion role, get in touch. Have a wonderful evening. Again, thank you, Kieran. Thank you for the BMJ for making this happen. And everybody at Medlearn, have a wonderful evening. And Kieran, thank you very much. And take care, everybody, and have a wonderful evening and stay safe. Thank you very much. Thank you very much.
Thank you.
Thank you.